Good afternoon, everybody. My name is Peter Smith. I work as a program manager in the quality improvement services at CNWL, and also introduce Alison Devlin, who's a former colleague of mine at CNWL, now freelance. How would you describe yourself? Freelance in the EDI consultant. What we'd like to do this afternoon is just to present to you a story of the journey of CNWL in CNWL's context as a NHS trust, and some of the lessons we've learned from research that was carried out within our services. And Alison was the instigator and commissioner of some research that was done. So I need to acknowledge that Alison is the person that actually really did this work, so she's here to talk about this. I'm speaking as representing the staff networks prior at CNWL, and I was the co-chair for the network for about 5 years. Okay, so just to let you know a little bit about CNWL, we're a very large NHS trust in London. We cover an awful lot of areas in London, Milton Keynes, Surrey. We've got quite a lot of staff, 7,000 staff, and we obviously have a very sort of diverse set of services in very many different locations. Fried at CNWL is the LGBT plus staff network. It was established with both Alison and I basically sitting in a room off-site so that everybody could come to meet with the network 7 years ago now. It's been quite a journey in terms of making sure that the network is publicised within the trust, and it's taken quite a while, as you see from this sort of timeline, to actually get to where we are today, and I'm going to talk a bit more about that at the end of the presentation. Our membership is quite large, but essentially we have a 1 to 7 LGBT self-defined membership to LGBT allies, and we're quite proud to say that we're almost 30% of all the staff within the trust are a member of Pride at CNWL. And I would advocate for the Stonewall Workplace Equality Index. We heard from Ruth earlier. It really has been instrumental in gaining LGBT equality knowledge and practice throughout the trust. And we've consistently been the top 100 since we started in 2014. It's hard work, but it's very well worth it. Okay, but no further ado, I'll hand over to Alison.
So the work that we carried out, first of all, it came from a complaint from a trans male patient. And this is on an acute mental health ward. And there had been breaches of his confidentiality. And in the discussion about what the trust was going to do about that, lots of other things came up, which was about staff attitude, about the language that was being used, about the lack of understanding that staff had, and also from a manager's point of view of saying, actually, if the staff don't know how they should be behaving, how can I take them down a disciplinary route until they know what they should be doing? So from that initial complaint came some work in association with the advocacy project, which was they provided mental health advocacy in the acute units within the 2 boroughs, but also they had an LGBT advocate who worked very closely with us. So she undertook a wider audit of patient experience, not just LGBT patients, but looking at patients from lots of different minority groups. And the results that came back from that audit was that the most significant differences between patients from minority groups and the majority were around patients with a learning difficulty, or learning disability, and patients who are LGBT. And so I took the LGBT element, and then we did some work on that. And the LD stuff went over to the head of LD services, who then organised their own sort of response to that. Okay. So Neil Churchill earlier was talking about the importance of looking at variations and differentials in patient experience. I think this is really important and something that I quote all the time, because if we're actually treating everyone like shit, that's not an equalities issue, that's a quality issue. And although you want to improve the health of the population as a whole, if you keep improving everyone's health, you don't actually address the inequalities. And improving everyone's health is an easier option, actually, because it doesn't threaten those in the majority groups. But you do have to address that differential. So, in this audit that was carried out, and bear in mind it's being carried out by a known advocate who's got the trust and confidence of the patients, and it's a set of questions are given or were given to patients after they had left the acute unit. So this is after they had recovered and gone home, but were still in contact with services. And they were asked 3 questions, essentially. They were asked about support. Do you think that your care and recovery has been supported in relation to your LGBT status? Do you think that about respect? So do you feel that hospital staff respect your LGBT status? And disclosure and discussion. If you have any issues relating to your LGBT status, do you feel able to disclose and discuss these with hospital staff? So, the results. Da, da, da. Right. So, there's the first question. Do you feel you've been supported in relation to your status? Yes, 19%. Do you feel that hospital staff respect your LGBT status? Again, 19%. And an even more worrying one, and which has been touched on by several people today, if you have any issues, do you feel that you'd be able to disclose these with hospital staff? Only 13% of the participants. So along with those quantitative figures is the qualitative feedback, of which we have tons. And when we've done training, which I'll talk about in a moment, we have used every single one of the quotes that came from that piece of research, which I lovingly typed out and laminated, and we have them on cards, and people in the training read them out, and it is the voice of the patient coming out. I must say, laminating those cards is an afternoon I will never get back of my life, but it has been, and I'm sure you'll agree, one of the most powerful messages of that training. So here are some of those examples. Some nurses called me she, some called me he. They were often talking in their own language and looking at me and saying my name. I got looks and whispers all the time. I was even called names such as puff, he, she, or hermaphrodite. It's hard to say as to whether I was respected. I never told them. I was asked several times where my husband is, and I'm lesbian. I think it was even worse when some of the patients adopted this attitude and started making obvious comments and fun of gay people in general. They didn't stop them. I would not have felt comfortable disclosing openly. They just didn't seem like the sort of people who would be able to, if not understand, at least tolerate my situation. And finally, I would rather not talk about this, because I fear if they know, I might get into trouble and I might have to stay here longer. Now, that's significant in mental health services, where inpatient stays are not 3 or 4 days. They are weeks, if not months. Oh, there's one more. I feel very supported here, but I do think the staff don't like LGBT people. One male member of staff freaked out when my boyfriend visited the ward. He only gave me a hug. It wasn't inappropriate at all. But I've learned that public displays of affection are forbidden if you're LGBT. He said very aggressively, "This is a hospital, you can't do that here." He insinuated we were doing something dirty, but it's okay for straight patients to hug and kiss their partners hello and goodbye. Lots of the quotes that we got through the audit were similar. So the themes, there were some themes that we took from the piece of work. The themes were that there was patient-to-patient homophobia that wasn't being challenged by staff. There was staff-to-patient homophobia and transphobia and harassment. There was a lack of safe listening ears. So when patients wanted to talk to someone, they just did not know who was to talk to. No one seemed to be asking around sexual orientation or any of the associated needs. And LGBT patients didn't feel the environment to be unsafe. They did feel it to be unsafe, stressful, and not conducive to recovery. Generally, there was a culture of LGBT patient silence and invisibility. And it's quite telling that when the advocate was asking people to take part in this, to answer those questions, there were some people, some patients, who she knew were gay, just because she'd worked with them for years, and yet they would not take part in this in case their responses negatively affected their future treatment. So we took this away. This was shocking. This was absolutely shocking. So we took this away and put together a sort of action plan. And when I say we, that was myself, the LGBT staff network, the advocacy service, and we were going to involve the patients themselves. And we had numerous conversations about how to involve the patients in any training that we did. Using the adage, nothing about me without me, we really wanted to include the patient voice. The trouble is, they were too scared. They were too scared to get involved in the training. So then we thought, okay, so we'll record their experiences and people can listen to their voices. And then they said they wanted their voices disguising. And then they were very concerned about who would hold these tapes and whether they'd ever be used against them. And in the end, the compromise we came to was for me, as I say, to type out all of their comments and laminate them and then read them out. So the training commenced in 2013, and it was across the wards in the acute mental health units. And it was an hour and a half training, which you might go, well, what's the point in that? That's what we could get. That was over handover time, so it's on the wards so that the late staff have come in, the early staff are just finishing, each staff can release 2 people. And that's what we had to do. We just did it loads and loads and loads and loads of times. And sometimes we got nobody, I think it would be fair to say, yes? And we had to go onto the wards and physically drag people up. And then other times we had a room full. Pardon?
Some people left.
Oh, yes. Yes, halfway through, one man I seem to remember, after signing in, as I reminded him, you signed in, love, I know you are, came and just slapped the paperwork I'd given out to them all straight in front of me on the desk and walked out. And I thought, right. So as soon as we'd finished, went off to see the matron. Marvellous. So yes, the training, the explicit message to counteract those findings, that it was required that a patient ask and consider sexual orientation and gender identity within their assessments. That people need to be a safe listening ear. Giving practical tips with language. So just forget this husband and wife things. So start with partner. All this gender neutral and sexual neutral language. And then when people start using their own language, then you reflect that back. We were very explicit over the expected staff behaviours and linked it to, what was that document called? It used to Used to be in the back of the disciplinary policy. You'll know it, Patrick, I'm sure. We never shared it with people when they started, but if someone broke it, they would have the full force of it whacked on them.
It's the staff code.
The staff code of conduct. You never saw it unless you broke it. It was really strange. So we made that an explicit sort of document. Because, as I said at the beginning, you can't discipline somebody if they don't realise what they're doing is wrong. Now, it's quite interesting because about 18 months to 2 years afterwards, there was an incident with someone two members of staff being transphobic to a patient on one of these wards. So the matron came to me and said, "Are they on your list of attendees?" I said, "I'll have a look." And yes, they'd been. She said, "Right, that's it then, straight into disciplinary." Because they cannot say they didn't know, because it's really clear what their roles were. The fact that staff have a role in challenging the homophobia from patients and from staff. And again, that it's just part of care planning and risk management. Okay. As well as being given information and contact, so a booklet that had details of Opening Doors London, it had details of Sexual Health Services, of Gallup, and all the other agencies that your average straight person just has no idea exist. So, the thing that I shall ever be known for, it'll be on my tombstone, I think, the rainbow lanyard. So, there you go. Approved by the Exec Board, formally launched, promoted to all new starters, people individually signing up, and I can't stress that enough. These weren't given out willy-nilly. These were signed up to people who said, "I will commit to do these following things." Okay. And they were given a newsletter and educational links to make them experts. As Peter said, we've got the straight allies that we launched, the sheer numbers of them in every ward and every service. They're like the strapline of the lager commercials in the 1980s. Straight and cis allies reach places other sexual orientations and gender identities can't reach. They are everywhere. So they are needed to spread this message. I totally underestimated, I have to say, the effect this would have, wearing a rainbow lanyard, on gay members of staff. They went from hiding their sexual orientation on the wards to being the local expert that people would go to and say, "Can I just speak to you about this? I've got a patient who." Okay. Changed their role completely. So, this is the best thing about this piece of work, is we carried out exactly the same questionnaire 4 years later. Do you want to see the results, boys and girls? Plus we asked, what do you know about rainbow lanyards? Other than that, it was exactly the same. Different group of people, but the same, different group of individuals, but the same group of people. Discharged, newly discharged people from the acute sector in these two hospitals. Oh, right. I've done fancy things with that. I've forgotten about that. Right. So we have Hospital A, Hospital B, and overall. And that's comparing the two results. So Hospital B, to go from 0% to 60%. Have you ever seen an improvement like that in a care quality improvement initiative? About respect. Hospital B had a lot of work to do, must be said. Okay. And then the most important one to me, which is about being able to disclose. Okay. Still not very high in Hospital A. Hospital B, yeah, we're getting there. Overall. And so here we go. The re-audit results. People thought the rainbow lanyards were brilliant. It was a clear message. There was a safe listening ear. So I came to the conclusion, I'm a pragmatist, I couldn't train everybody to be pro-LGBT. So for the safety of the patients, I was going to teach them where the safe ears were, and that's the way we went. And so this was some feedback then, said that actually patients didn't know what it was for. I had anticipated that the patients who needed to know would know what a rainbow was, and would start that dialogue with the member of staff. We needed a bit more around it, and so we produced these posters, which went around. And that is David Van der Velde, who's the current chair of the LGBT network in CNWL. And that's the point with those posters that I left the organisation to move on. So I'll have to just hand you back very quickly to Peter to follow on with where we are now.
Okay, so I'm going to make this really, really quick. I've just got 2 slides. We talked about the awareness training. We have developed the awareness training over the 4 years that we've been doing it. We're now doing a much more rigorous revision to include more the trans identity, and we've despite when we started off we couldn't get anybody to actually come into the training room with us. We've actually getting sort of videos of our trans staff actually standing up and talking about their journey. And that is really in relation to the one question that we kept getting from our staff about LGBT, understanding the LGBT inclusion was what do we do about trans patients on the ward in the single-sex environment? So we're trying to address that, and so that they can understand that it's individual, and you cannot actually have a policy on this that's going to fit every single situation you're going to be presented with. So a challenging agenda, but we're moving that forward. So that's the start of our awareness training. We have social networks stuff going on. We've been in Pride in London for 6 years now. They're the T-shirts that we use. As we go through the years, we're moving through the rainbow, so that we've got all the colours of the rainbow in our T-shirts. There's NHS 70, the ahead of 2018 Pride. We're very glad to be there. We make a big thing about LGBT History Month, so we make it very visible that the staff network is active within the trust. We have a quiz, and we have sort of prize giving nights and things like that. I already talked about the Stonewall Equality Index and reiterate that, and we've been top 100 for quite a long time. We've arrived in terms of the workforce strategy for the trust. It now recognises that the work of the staff networks, and there are 5 networks covering BAME, disability, lived experience, and carers, as well as LGBT, and that they're now part of the executive director's objectives for the year. So I think we've really arrived in terms of getting on the within the exec, and evidence of that is that we now do reverse mentoring with the exec directors. So I and David, one of the co-chairs, actually go and tell the executive what they need to be doing about LGBT inclusivity in CNWL, which is it was quite scary when I first started doing that. One more thing, we've been recognised. We now have a GEM award, which goes the extra mile, which is our annual awards to staff. It took a couple of years to actually convince the exec that we should actually have one specifically for the staff networks, and I must say I was very honoured to receive that last year. We do a lot of work with charities. We work with Gender Intelligence, Stop Hate UK, and Opening Doors. Jim's been to see us, and we do co-work with them. And here's our current co-chair, David, who ran, how much was it, 250 kilometres, not all in one go, to raise money for Opening Doors London. External work, just a quick example of that. So I was asked to write a article on some of this stuff that we did about sort of equipping our staff for working with LGBT communities, for the newsletter for the Royal Society, Royal College of Psychiatrists. I'll get it right. Intersectionality is where we need to go. Staff Networks Day across all our staff networks is something that we're working on to develop in the next year or two. And there's so joint twittering, tweeting is we use Twitter quite a lot. And our lanyard has been a success. I can't claim it's just CNWL that has made the lanyard popular, but we were the first, and it's now we've got sort of lanyards being put on. Rainbows being put on all sorts of lanyards and in all sorts of areas. So we're really, really glad that's been taken up widely across the country. I would say we're not here to just sort of say, oh, haven't we been brilliant? We're here for you to shamelessly steal from us. If there's something that you're actually interested in to take up and use in a network, network's firing up over there, please do and talk to us about it, because we're not precious about this. It's not IPR. It's about sharing. It's about getting the good practice out there. So thank you all for everybody. Here's our contact details. I think that if it's going around, then they'll be in the pack that goes out. Thank you all.